All right, perfect. Thanks for recording, Elise. So my name's Ben. Ben Reich. I'm a medical student at the University of Washington. I'm a Pacific Northwest board member. So I have the honor of introducing Dr. Ann Lima for our quarterly talk. Um, a little bit about Dr. Lima is that she is a physician at Clearwater Valley Health in Orofino, Idaho. She prides herself as a rural family doctor, specializing in all aspects of medicine, including emergency medicine, hospital medicine, primary care, and obstetrics. She's been a panelist and participated in multiple ECHO Idaho programs. She serves as a clinical instructor for WWAMI and the UW School of Medicine, as a guest lecturer for Idaho medical students and precepts for various levels of learners, including medical students, residents from multiple programs, nurse practitioners, and PA students. She serves as the medical director for Clearwater County Ambulance District and Backcountry Medic Search and Rescue, serves as the Idaho State Emergency Medical Services Physicians Commission, and is a medical director for local hospice patients through Elite Home Health and Hospice. She started a walking program, Walk with the Docs, to promote safe spaces to exercise with local healthcare providers. The Mary Lou Triathlon she started in 2020 is a growing local event as well. In her free time, she enjoys anything active, being outside, traveling, and volunteering for various local nonprofit organizations. And I'm proud to say she was one of my very first preceptors in medical school. So without further ado, Dr. Lima, please go ahead.
Thanks, Ben. Yeah, love teaching, love wilderness and wilderness medicine. A little more about me. I actually grew up in the Midwest. So I grew up in Minnesota on a dairy farm out there, and went to the University of Minnesota for undergraduate, and eventually medical school, and also got my master's in public health from there. But I like to say I took the scenic route. I lived abroad for a little while after college. I lived in Ecuador for a year. During medical school, I took a little bit of extended time to do 2 years of research in Uganda and just kind of living life there, and have had the opportunity to kind of work and live other places in the world, and had great opportunities to meet some amazing people, mentors along the way. So I eventually after medical school, I eventually landed in Ventura, California, where I did my family practice residency. And then I worked up in Juneau, Alaska for a summer, and then ended up in Orofino, Idaho at this pretty amazing critical access hospital on the Clearwater River in north central Idaho. So anyway, so I got a pretty big plate full of things to talk about today. So we're kind of gonna try and spend the first, 20 or so minutes just kind of running through some slides of some basics of wilderness medicine, specifically like high altitude illness, hypothermia, frostbite, and different types of heat illness.
Talking in my ear.
And then we'll do some interaction after that. So does anybody know where this is? What mountain this is? Any ideas?
Are you in Kilimanjaro?
Yes, that is the top of Kilimanjaro. When I lived in Uganda, I had the opportunity to climb, so that is the highest elevation I have ever been, but plenty high. So we're going to just talk a little bit about high altitude illness and then treatment and prevention. Anybody have any idea where we're on top of which peak this is?
Oh, don't make me answer everything, guys. I'll call you out. Everyone who's participating.
Okay, well, anyway, this is the highest peak in the lower 48. So this is Mount Whitney in California. Okay, so just kind of talking a little bit about high altitude illness. And so we're not going to get into the pathophysiology, which is actually super fascinating, but really there's a lot of factors that affect your ability to cope at high altitude. And so there's kind of a few things. There's things that are things you can control and things you can't. And so the degree of hypoxic stress that you're putting on your body. So that would be like how fast you're ascending, and as well as like how high you're going. Like, are you going Kilimanjaro or are you going like Everest? So, so that's like 10,000 feet, an altitude difference between those two. So, there's quite a difference depending on, of the hypoxic stress that you're putting on your body. Then there's like, what is inside you? Like, what do you have in terms of your own genetic or anatomic variations that can be affected in terms of how you are going to be able to cope with high altitude, any medical conditions you have, and then based on those medical conditions, like what medications are you taking? And then a big factor is alcohol when it comes to altitude. So these are all things, that can affect how well you can acclimatize and reach your goal. There's usually what we think of as three types of high altitude illness. There's acute mountain sickness, there's high altitude cerebral edema, and high altitude pulmonary edema. And so these are things we're going to quick talk about. So acute mountain sickness, this is kind of how you feel just a little kind of tired, headache, fatigue. You don't really want to eat very much. You may feel nauseous. And you kind of feel a little bit more short of breath when you're trying to exert yourself. This is not uncommon, and something that I had to discover on my own is that I end up feeling this around 10 to 12,000 feet above elevation is where I kind of hit acute mountain sickness. And that's something, you have to know about yourself in terms of what altitude you start having symptoms. We're going to talk a little bit about high altitude cerebral edema. So this is when you're having swelling in your brain. So things that are going to go along with that, like neurologic symptoms. So encephalopathy, so not thinking or acting normally, the inability to walk straight, so ataxia, feeling super lethargic, and then just a really kind of change in your how you're interacting with your attitude with other people. So this is high altitude cerebral edema. So these are things to think about. High altitude pulmonary edema. So this is when you're going to have a non-productive cough. So but occasionally, like as this cough continues, you may actually even start coughing up blood. And so these are, and you're going to get more short of breath with any exertion. So you're having a really hard time, taking a few steps when you have pulmonary edema. A lot of times this does happen with altered mental status. Something that you probably won't have out in the field, like an x-ray machine. But, if you're on a rescue team, you may have a portable ultrasound with you. If you're on a rescue team, like a butterfly or whatever you use. So that's pulmonary edema. So for any risk factors, for high altitude illness, so we already talked about, past history of high altitude illness. So like, I know when I get to 10 or 12,000 feet that I'm probably going to have symptoms, how fast you're going up, the altitude that you get to, and also the altitude that you sleep at. You really want to avoid vigorous exertion at altitude before your acclimatization. And then also like any comorbidities that we talked about that could have a problem. Specifically, pulmonary hypertension is a big one. Just vigorous exertion, you'll notice like, coming from close to sea level where we're living now, just in the last year, I was in like Cusco, which is about 11,000, a little more than 11,000 feet above elevation. And just, going up the stairs at the lodge just kind of gets it out of you a little bit, just at that elevation, at least for myself. So I can run a 15-mile trail run 2 days ago, but there I can barely make it up the stairs. So the biggest treatment for any high altitude illness is descent. That's kind of the number one thing that you're going to do. So there's also oxygen therapy. There's hyperbaric therapy that a lot of rescue teams have a gamma bag, which is like kind of a giant inflatable cylinder that you can, set to hyperbaric pressures and put people in that. And then there are medications. There's kind of 3 medications that we use both for prevention and for treatment. So nifedipine is a calcium channel blocker, and that's used for high altitude pulmonary edema and cerebral edema. Acetazolamide, which is a carbonic anhydrase inhibitor, like a diuretic, and that's used for cerebral edema and pulmonary edema. And that's actually my choice for what we use to prevent high altitude illness. And then there's dexamethasone, which is used mostly in cerebral edema, and that is obviously a steroid. So we talked a little bit about prevention. So those same 3 medications can be used for prevention. Acetazolamide tends to be the most well tolerated. Some of the side effects that you notice is it kind of changes the way the food tastes a little bit. And it also is a diuretic, so you have to try really hard to stay hydrated. The reason I also like that is because you can take it for longer periods of time. Dexamethasone is something that you don't really want to take for more than 5 to 7 days. And nifedipine, if you have any blood pressure issues, this is going to decrease your blood pressure significantly. So these specifically, you usually take actually until you start descending. So you know, like if I'm on a hike, multi-day hike, usually when I get to the highest altitude that I'm going to get at and then continue to decline from there, then I'll stop taking these preventive medications. Whew, okay, so that's a quick go at high altitude illness. Anybody have any quick questions before I continue to move on? Okay, so this is hypothermia.
A really quick one.
Yeah, go ahead.
Yeah, why would you use nifedipine over another calcium channel blocker? Is it just more central acting, or what's the rationale there?
So you mean like as opposed to like a non-dihydropyridine calcium channel blocker, or just like something like amlodipine that's in the same category?
Something in the same category like amlodipine.
You know, that's a good question. I can't say I know the answer in terms of why that it's used over amlodipine, and maybe it's possible, but these are kind of the meds that you would use. I'm trying to think if there's something specific between them. I can't think of anything specifically, but yeah, I would definitely use them. They're you know not going to be an AV nodal blocker, so you don't want to use like you know verapamil or diltiazem for that. But so nifedipine over amlodipine, but I'm not exactly sure the reason for that. Okay, any other questions? Okay, hypothermia and frostbite we're going to try and get through. So I'm kind of skipping over a lot of the hospital treatment for a lot of these things because we're just kind of doing field treatment for all of this. So hypothermia is defined as a temperature below 35 degrees Celsius. And so anything below that, we're going to go into like mild, moderate, severe hypothermia. And so the first things that you're going to see with mild hypothermia are, if you're thinking of like slow brain, but fast heart and lungs. So you're going to be tachypnic, tachycardic, and kind of hyperventilating. So fast heart and lungs, but then slow body, like slow neurologic. So you can have a little bit of that ataxia, dysarthria problems, you know, speaking, a little bit of CNS depression, but you should not be comatose at like a 32 to 35 degree temperature range. When you get into the more moderate hypothermia, which is going to be 28 to 32 degrees Celsius, you're going to actually see your heart rate go down. And so you're going to see bradycardia. And then you're going to have more extensive CNS depression at that level. You are going to see also some, like a lot of atrial rhythms, kind of as you get into moderate to severe hypothermia, kind of like atrial fibrillation, but with a really slow rate. And then when you get into severe hypothermia, that's going to be less than 28 degrees Celsius. And that's where you're going to get like cardiovascular collapse, hypotension. In moderate and severe, you're going to get these kind of like junctional bradycardias. And then you can actually go into VFib, which I'll talk about in a minute. but severe CNS depression at this point, and so no reflexes, usually like GCS of 3. So the first thing you want to do is try to rewarm them. So this is hypothermia. We're going to talk a little bit about frostbite in a little bit. So you want to do passive external rewarming. So the thing you want to do is if wet clothing needs to go off and you're going to cover them with warm blankets. Another good thing to think about is some type of insulation with, and also with a vapor barrier over it, so that you're keeping in all the heat and moisture that you have, in terms of not trying to prevent heat loss. If you have warmed IV fluids, like if you're part of a rescue team that would have warmed IV fluids, that would be something that you could potentially do in the field. The one thing you want to avoid is rubbing of the skin. We're going to talk about that with frostbite, because sometimes these can, as you can imagine, come together. And the other thing you want to do is avoid really rough movements of the body. You got to be really smooth when you're moving people with especially moderate to severe hypothermia, because significant movement can induce ventricular fibrillation, which is extremely hard to stop even with defibrillation until you get their core body temperature up till more than 30 degrees Celsius. Okay, quick and dirty on hypothermia. Feel free to stop me if you want to go forward. And this is a really cool picture. This is from a sunset in the Dolomites. This is in September in the Italian Alps that we were just in this last September. Some amazing hiking in the Dolomites. So I'd suggest that anytime. Okay, so frostbite, we're going to get into different. So when we think about frostbite, we're talking about severity. Okay, sorry, I had it. We're talking about severity based on the depth of tissue involvement. This is kind of how we do for burns. There is a lot of similar like treatments and like wound care for frostbite as and burns. So, and actually in the hospital, if you have somebody with severe frostbite that you're doing significant treatments for, the best place to send them actually is a burn center. Somewhere that really has a lot of experience dealing with tissue involvement, whether burn injuries or freezing injuries. So we're going to talk about kind of classification similar to that. So the first thing that you might notice is something called frostbite, which is a superficial non-freezing cold injury. So what you're doing is you're getting vasoconstriction at all your exposed skins, which a lot of times we think of about like nose, fingertips, toes. And you actually get little ice crystals on the skin surface. It does not freeze the tissue underneath, but this is kind of the precursor. So if it continues to go on, you will see frostbite going into that. So after that kind of frost snip or superficial, freezing injury, you're going to go into first degree frostbite, which is still superficial. That's when you're going to start to get numbness in your fingers. They're going to turn a little red and have swelling. And then what happens after kind of that erythema, especially with the frost snip, is you can actually have the tips of your fingers turn white or yellow and get this firm, slightly raised plaque on them. You're not getting gross tissue infarction, but you may have a little bit of sloughing of that top layer of skin. Now you're getting into second degree frostbite, and this is when you're going to get blisters on your finger. That's kind of a distinction. You're going to first get clear or milky fluid in those blisters, and a lot of times that develops within 24 hours of a freezing injury. And eventually, like after that blister forms an eschar later on, that could slough off, and usually there's healthy tissue underneath that. And again, this is no tissue loss. So frost snip, first degree and second degree frostbite, those are all superficial frostbite. Now we're going to get into third and fourth degree, which is going to be more of a deep injury. So third degree frostbite is when you're going to have usually like hemorrhagic blisters. So we're thinking about kind of on our fingers specifically, kind of the most common place. On your nose is also a very common place. So now you're getting into the reticular dermis and beneath that vascular plexus. So you're going to have those hemorrhagic blisters, and then it's going to get a black eschar, and there is going to be some deeper frostbite. Fourth degree frostbite, never seen this, but You can, get that frostbite extend into muscle and bone, and you can have tissue necrosis and eventually mummification. So this is like amputation level that we're looking at. So, kind of, I gave you that frostnip 1, 2, 3, 4 degree of frostbite, but there's also kind of what we talked about, really superficial. We're not really getting much tissue loss, to the 3rd and 4th degree, which is deep, where you're considering severe injury and tissue loss. This is kind of that schematic again, kind of describing where we're at. So normal, frostnip, 1st and 2nd degree, 3rd and 4th degree. So, I mean, the biggest thing in the field is to prevent frostbite. So, so that's like the thing that you really want to be able to do. You want to keep your core temp up and make sure you're hydrated when you're out in cold temperatures. You need to make sure you're insulating all your body parts, making sure, all your skin is covered. You don't want to have constrictive clothing or footwear. You want to be able to make sure that your peripheral perfusion is adequate, making sure you're eating, and also, kind of getting a little bit of exercise and making sure that blood is flowing specifically. A big thing with all of these, when we're talking about heat, when we're talking about hypothermia, when we're talking about altitude, avoiding medications and substances, especially alcohol, is like of the utmost importance. So with frostbite, so trying to get the person to a warm environment and get that wet clothing off. One of the things about frostbite is trying not to have multiple freeze-thaw cycles. So what you don't want to do is you don't want to be somewhere and like thaw fingers and toes and stuff out if the plan is that it could possibly refreeze. If you have a multi-day hike out, you actually are going to not try to thaw those until you're in a definitive area where you're not going to refreeze them afterwards. So trying to not walk on frostbitten feet. Obviously, sometimes this may have to happen depending on what the situation is. You can kind of put frostbitten fingers like in your axilla, in your groin. So that's kind of some pre-hospital warming. We talked about not warming them. That can cause some further tissue damage, and kind of really the only medication initially, like in the field, would be ibuprofen. Kind of later on, people are in the hospital, there's some other medications that we could consider, but really ibuprofen is probably the most helpful and the most accessible in the field. This is just kind of the algorithm from the Wilderness Medicine Society. Kind of just talked about that, but they have some, the Wilderness Medicine Society has like really great guidelines. Other than ibuprofen, you can use like topical aloe vera, but really the kind of the medication that we're talking about is ibuprofen specifically. Those are kind of some references for frostbite and hypothermia, and then we'll move on to heat illness, unless anybody has some quick questions. Like I said, this is just like a fly through, and then we'll kind of go through with a little more interaction soon after. So hyperthermia. So this is when your body temperature rises to a point where you're really not using all of the mechanisms that we have to cool ourselves, when those are being impaired. So that can be impaired by things that we have on, drugs, specific diseases, or like overwhelmed by significant temperatures. So there's, humidity, heat. These can all be taken into consideration when you have like an environmental situations. And then there's also kind of your own internal metabolic heat production, but these are all things where your kind of body is not responding appropriately because of all these factors to heat production. So kind of the kind of first things are usually heat edema and heat cramps. And so this is a lot of times what we see is leg swelling, because you're getting a lot of interstitial fluid pooling. And then you have heat cramps, which are a lot of times you already have the heat edema, and then you're starting to get involuntary muscle contractions, calf contractions, like usually during or right after exercise. So the big thing, especially for edema, edema, you're looking at elevating your legs and putting compression stockings on. Those are the best things for edema. And then with any kind of heat illnesses, usually just some oral isotonic or hypertonic fluid hydration can be very helpful in terms of treating this. If we kind of get onto some more severe heat illnesses, or more severe than mild, so we're talking about edema and cramps is kind of a mild category. Now we're getting into the moderate categories of heat syncope and heat exhaustion. So heated syncope is exactly what it sounds like. It's a transient loss of consciousness, and then, coming back to a normal mentation, normal mental status after that. Heat exhaustion has a core temperature usually to 37, but not to 40, because 40 is where we're going to hit heat stroke. And we're going to talk about that in a second. But a lot of these things that you're going to see in heat exhaustion are like really thirsty, feeling very, very weak, uncomfortable, pretty anxious, very dizzy. And then it might also include episodes of syncope or heat syncope with that. So, and yeah, this is a temp greater than 37, but less than 40. So in those moderate forms of heat illness, you want to get that person out of the heat source. And then you're going to use some type of convective or evaporative cooling method. So that's like water with a fan, cold immersion, things like that. And then, if you want them to try and drink, if at all possible, some, isotonic or hypertonic fluids. And if you have access to IV fluids, that would be another thing. So getting into heat stroke. So this is the most severe heat illness. This is when the core temp is greater than 40 degrees. You're having a lot of altered mental status, again, like encephalopathy, like we saw with hypothermia. You can also see seizures and a coma, like a GCSF3 as well. So, and that can be from, that exposure to environmental heat, or your own strenuous exercise, like increasing your metabolic rate yourself. So kind of the things that we all learn for, life-saving courses in wilderness medicine is you got to think about your ABCs. So you're going to get that patient away from the heat source. You're going to support their airway, breathing, and circulation. And then cold water immersion is actually the preferred method for treating heat stroke. Trying to do IV hydration and then evacuating them out of the situation. So, and this is another, Wilderness Medical Society clinical practice guidelines. This one is specifically for heat stroke. So, okay, so I'll kind of leave it there. And so then the next thing that I want to do is I'm going to kind of do an interactive game. So let me close this actually, and I'll stop sharing, and then I'll get my other presentation ready, and then we will, so I don't know how many people we have here, but I was thinking about making maybe 2 teams, or we can just go through the questions one by one. So we're going to play Jeopardy. Ben, do you want to figure out how people want to be set up?
Yeah, maybe we'll just go through the questions one by one, instead of doing the team thing. Does that work for you, Dr. Lima?
Sure, that's totally fine.
Yeah.
Okay.
And then I'll just monitor the chat. So I see someone doesn't have a mic on, but if people want to throw out their answers into the chat too, I'll just monitor that, and then I can just sort of speak for people as well.
Okay, can you guys see now?
Yes, we can see it.
Okay, let's see. So I'm just reading a comment from Adam Lund. I haven't heard of heat syncope specifically broken out before. Feels like a retrospective diagnosis. Yeah, so this is, so if they don't have any other severe illnesses, like they're not, hitting a classification for heat exhaustion or heat stroke, that is something that you can consider in terms of the diagnosis. There is no double jeopardy. So, I don't know if anybody wants to start at a specific spot, or we could just go through, since Adam made the most comments, Adam, I just want you to pick a category that we'll start at.
Oh, let's go with altitude for 10.
Okay, all right, that's my favorite anyway. Okay, so this is kind of the situation here. 21-year-old college student has a headache at 3,800 meters, resolves with Tylenol, but then comes back when they go up a little bit further, goes to sleep and wakes up at 5 o'clock in the morning in the tent, can't walk to the toilet, feeling really short of breath, no significant past medical history, just taking the Tylenol and a Chinese herbal diuretic. These are kind of the vital signs. So we're seeing a heart rate of 130, respiratory rate of 20, oxygen saturation 42 to 47%. You're listening, you hear crackles in their lungs. You don't have any swelling in their legs. They're needing some assistance to walk. What would this diagnosis be?
We have Adam in the chat with, oh, sorry, someone else can go ahead and speak.
I was just going to say I agree with Adam in the chat that it's HAPE.
Yeah, for sure. Good. So that's HAPE. All right, I don't know. I think that was Brandon. Brandon, do you want to go down to altitude 20?
Yeah, let's just go down the list.
Okay. So what's our treatment for HAPE? Give me like 2 things you could do.
Descent and oxygen.
Yeah. So going down is always the number one thing, doing oxygen. This one you can use nifedipine kind of on your way down. You can also use acetazolamide with nifedipine kind of after you get down descent. And then this is the hyperbaric treatment. If you can get in a gamma bag, that would be good too. Okay, who's up next? Amy? Okay. What are the 3 medications that we use for prevention of high altitude illness?
Got Adam in the chat again with calcium channel blocker, acetazolamide, and Dex. I'm going to also say nifedipine for the calcium channel blocker.
Yes, exactly. Yep. So nifedipine is the calcium channel blocker that is there. So, yep. And this is kind of the dose that you could do, and we talked a little bit more about that. So what's the treatment of high altitude cerebral edema?
Is it descent?
Yep, always descent is the right answer. What else?
We've got another person in the chat saying all 3 medications as before.
Yep. So, yes, initially you're going to treat like with dexamethasone and nifedipine when you're kind of en route, and then hyperbaric treatment, and then you can do all of these medications after descent as well. The nifedipine, acetazolamide, and dex. Okay, give me like 2 risk factors for high altitude illness.
We've got in the chat previous high altitude illness.
Yep, that's one. Give me another one.
And pulmonary hypertension in the chat as well. I also see
No, yeah,
descent level.
exactly. Yes. So rate of ascent, the altitude you're going to go to, exertion before acclimatization, and then kind of those comorbidities like pulmonary hypertension. Okay. Who wants to pick another category?
I always like miscellaneous.
Okay, all right. So, initial pain medication for frostbite. Yes.
Ibuprofen.
Yeah, good job. Yep, ibuprofen. So, it can provide pain control, but it also can block harmful inflammatory mediators, which cause vasoconstriction and deepen the injury. So that can be helpful in a couple different ways. And then you can also use aloe, but good job. 20. So if you have somebody with heat stroke, what temperature are you trying to cool the patient down to? I mean, at a minimum, where would you want them to be? Maybe this one isn't quite as straightforward. So, but heat stroke is when you get to 40 degrees Celsius. So, yeah, back to where they can regain their own thermoregulation eventually. But you want to get them down to 39 is the goal. Yes, below 40 exactly. What's the elevation of Mount Everest within, I don't know, 100 feet?
29,000 feet.
Yes, that is correct. So it's I mean you'll get like a foot on and off, but it's like 29,032 feet. Or 88,849 meters above sea level. So that's high. So what medications other than IV fluids are indicated for the treatment of heat illness?
We've got ISO or hypertonic oral hydration in the chat.
This is kind of a little bit of a trick question because really there's no medication. Yes, like fluids or something that you're thinking about, but I guess what I was trying to get at is really there's no medicine that we give, and you actually don't want to use antipyretics in the setting of like severe heat illness. So let's see. All right, give me 2 ways to prevent frostbite. Clothing and activity, some exercise, and kind of I think there's 2 things with clothing, right? You want to have layers of insulation, but you don't want it to be too restrictive. So yeah, don't constrict your clothing or footwear, making sure you have all that insulation. I wanted to say isolation, which is not. Okay, who pick another category? Elise.
Let's do heat.
Okay, we'll go down heat for 10. So when you have heat edema, like, stopping the physical activity removed from environment, and what other 2 things can you use in the treatment of heat edema? Compression, yes. And one other thing, rest, compression. Well, that's kind of cessation of physical activity. Elevation, yes. That's what we're looking for. So compression stockings and leg elevation are what we're looking for in heat edema. What's the optimal cooling method for heat stroke?
What is water immersion?
Yes, or specifically cold water immersion. That's exactly what you're looking for. All right, heat for 30. So heat stroke is defined with a core temp of what? Yes, 40 degrees. That's exactly greater than or equal to 40 or 104 degrees Fahrenheit. So if you have a transient loss of consciousness and then you get back to your normal mental status in the setting of an exposure to heat, what is that called? Yes, heat syncope, exactly. All right. Of these medications, which one could increase your risk of heat illness?
Furosemide?
A, B, and C. You are all right, but it is all of them. All of them can cause an increased risk. Okay. Corey, give me frostbite or hypothermia.
Let's go hypothermia for 10.
Okay. So hypothermia is defined as a core temp below what degree in Celsius? $35. You know, in terms of the clopidogrel, there's a quick question about how clopidogrel causes an increased risk of heat illness. And that, I mean, it has to do with its antiplatelet properties, I would presume. And so kind of adjusting the way that your body is responding. So all of those medications, what they're doing is they're impairing like your inherent response to a stressor. And so when you're taking away those inherent responses, which like if you've had a stroke or, you know, a heart attack with a stent, or, you know, you have heart failure, these are all medications that, you know, we're looking at the benefits are outweighing the risks, but on a day-to-day level, but, you know, putting people in, you know, an exertional situation or a heat situation is bad. Like, I don't know, a few years ago, we were hiking in the Corcovado National Park in southern Costa Rica with a gentleman that was, you know, on medications for blood pressure, and he just really kind of failed like in the heat. It was a long hike. You know, and I was kind of discussing what medications he was taking, and he was taking like a diuretic and I think like an ACE inhibitor. And so he was taking a bunch of medications, and I think actually he may have had an antiplatelet on board as well, but those are kind of all medications that are gonna that are working to fix a problem that you already have, but are gonna impair your inherent ability to fight any of these stressors, especially in heat. But yes, you guys were right in terms of hypothermia is a core temp below 35 degrees. So it's kind of interesting too, because like we have this mild, moderate, and severe hypothermia, but there's the ICAR, so the International Commission for Alpine Rescue is huge into that, and they have kind of levels, kind of like grade 1 through 5 in terms of hypothermia. So they have like 2 levels, even low lower in temp than kind of these mild, moderate, and severe hypothermia. Okay. What are some, give me like 2 symptoms of mild hypothermia. Shivering, okay, tachycardia, increased heart rate. Yeah, so when we're talking about kind of fast heart and lungs, so hyperventilation, tachycardia, tachypnea, and then sometimes you actually get a little bit of a slowness in your mental, like a little bit of dysarthria, which is slurred speech and a little bit of confusion along with that, but shivering especially as well. Okay. So if you start moving a patient that is moderate to severe hypothermia, what arrhythmia are you worried about it potentially inducing?
What is SVT?
It is actually VFib. Yep, so ventricular fibrillation. Looks like Brandon had it down here. So that's the one that we talked about, VFib. And that really it's hard to treat ventricular fibrillation, which is, you know, with defibrillation until your core temp is above 30 degrees. Give me kind of 2 elements of passive external rewarming. Yeah, so yes, removing wet clothes, insulation, so warm blankets, insulation with a vapor barrier, all important things for passive external rewarming. So, and just a little more thing, like it can be kind of in people that have that are unable to kind of increase their metabolic rate by shivering, that can be a problem in people. So in elderly patients, people that are super sick, you know, have been starving for quite a period of time, have sepsis or severely dehydrated, this may not be quite as effective. Okay, hypothermia. Moderate hypothermia, give me a couple signs or symptoms. Annalise, how do you take a core temp in these patients? So really what we look at, so for most of these things, we're looking at a rectal temperature for both heat illness and for hypothermia. That's kind of where we go. There is actually one of the things that we also use, especially when we're trying to rewarm or heat someone in hypothermia, we actually have bladder temperature sensors. So there's thermometers that you're putting inside, like with a Foley catheter, inside the bladder to get more of a core temperature. Yes. Lack of shivering. Have you guys, these are all good answers. And the other thing to consider, have you guys ever heard of paradoxical undressing? So that's another thing that happens in moderate hypothermia. So you're kind of in the mild hypothermia, you're getting like fast heart and lungs, I guess, you know, and then you kind of start slowing down in moderate hypothermia with bradycardia and hypoventilation. You're going to have more of a central nervous system depression. You kind of stop shivering a lot of these times, and you have this paradoxical undressing where you get really confused and you start taking off your clothes when you're already hypothermic. So, and then we talked a little bit about those usually atrial rhythms like atrial fibrillation, but usually it's in a with a slow ventricular response. So you're not seeing that rapid ventricular response usually in moderate hypothermia. You get these junctional bradycardias. And then we talked about kind of depending on where you're at, kind of movement can induce ventricular fibrillation. Okay. All right, frostbite for the last bit of this. So tell me what level of freezing injury this is. Yeah, good job, Adam. So this is frost nip. So I mean, redness can kind of go from frost nip to first degree. It'll eventually turn red, and then sometimes it can start to kind of go into white with the plaques, and that would be more first degree, but this is definitely kind of that picture is more so frost nip, and you may just start to have kind of a tingling sensation and numbness in your fingertips or whatever part of your body that it's being exposed. Moving on, what do you think this level of freezing injury is? Yeah, for the most part, Adam, like in terms of burns, you don't know the degree until later. Really, the big part with frostbite is kind of how we talked about superficial injury and deep injury. And so one of the things that we didn't quite talk about is kind of some of the hospital breakdown in terms of frostbite. And you actually end up getting a nuclear study called a bone scan to really look and see like how deep the tissue injury is. And so that's kind of one of the things that you can look at later, but really we're kind of looking at based on symptoms and what the hands look like, we're kind of looking for superficial or deep. But these like kind of the things that we talked about is we're kind of looking at so what I think of is like red fingers frostbite, like white fingers with like a little plaque on them, 1st degree. Blisters start occurring more so in the 2nd degree, but it's still a superficial injury, and those are usually clearer white fluid in them. And then when you're moving on to like dark fingers, hemorrhagic blisters, that's you're getting to the 3rd and then 4th degree when they're really dark and you're getting into gangrene types of or mummification of digits. So I think I probably kind of already gave this one away. So yeah, so we're still looking at superficial, but like clear milky fluid into that 2nd degree frostbite. Okay. So what of these things do you not want to do in the pre-hospital setting? Correct. You guys got it right. A. So you don't want to rub the affected tissue, but you want to get into the warm environment, pad or splint the affected areas, and kind of using that warm, so either warm water, not hot, or using your own body heat. Oh, I don't know if I talked about this today. So we'll see. We'll see if anyone gets this. What's the one recommended infection prophylaxis medication recommended for frostbite? This is a little harder. So it's not actually technically an antibiotic. It is tetanus booster. So update their tetanus booster to prevent for tetanus prevention. So there's actually in frostbite, there's not a routine use of prophylactic antibiotics, but kind of like burns, if at the first sign of infection, then you want to treat that. So the whole goal of like, burn care, wound care, frostbite care, a big chunk of all that is preventing infection. So I think we have one question left, and I think might even get done on time. So identify the true statement here, like. All right, looks like Adam and Haley got this one. So yeah, D. So circulating warm but not hot water. So we're looking kind of in the 37 to 39 degree temperature range. Dry heat, it's kind of really hard to regulate. I mean, for any of you who have like tried to warm up your hands in front of a fire, it's either like burning hot, ice cold, burning hot, ice cold, a lot of times. So and then just kind of the thing to talk about, there are kind of some more studies going on in terms of frostbite and trying to extricate people from like austere environments. And so whether or not, walking on feet or, frostbitten feet or things like that, how much tissue damage is happening. But the one thing that kind of still stands out is that you're trying not to rewarm and thaw out body parts that are going to get refrozen. So. Okay, that's it. So that was my talk. Wow, it is like 7:59. I can't believe we got through all that. It was kind of a whirlwind, so I hope I hope everyone got at least a snippet of information, and Ben has my contact information if anybody has any questions, but yeah, look forward to, just love talking about wilderness medicine just from like a professional